I was drawn to oncology mostly because of family dynamics and the psychosocial issues behind it. Did a clinical fellowship at St. Jude, immediately started doing late effects. So I had not pushed chemo since the first year of my fellowship. I only took care of long-term survivors. And I don't know how much interaction you've had with long-term survivors of childhood cancer, but basically, as somebody who primarily does that, I navigated subspecialty care. I took care of basically really complex medical kids and funneled them into the subspecialty care, screened for what they needed, and then funneled them into the care they needed. Very soon after that, I got involved in a camp for kids with cancer in Montana that evolved into a camp for adolescents and young adults with cancer in Montana, where they would come a week at a time. It's much better now, but care for adolescents and young adults with cancers was very segmented 20 years ago. And almost every adolescent with cancer felt completely isolated in their experience. Most were treated in adult centers where they surrounded by 80-year-olds. And the rest, because of the presentation of ALL being the most common, would be in a waiting room with a bunch of 5-year-olds and just always felt completely out of place. So the magic of the community of bringing young adults together, 40 or 50 from across the country, where they realize that they are not the only person who has the challenges that they have, is a really magic thing. But I basically was running a nonprofit, not doing much medical care, and was looking for change 15 years later. By the way, Randy has been to camp twice? 3 times. Once wasn't memorable. So was looking for change to kind of get back into more medicine, and was flipping through peds. I mean, I really was not looking hard. I was just looking. And this thing popped up. It was a brand new eating disorder hospital in Durham, North Carolina. And I'm like, I pick up the phone, make some phone calls, and I got a call from the CEO at the time, and it really clicked. Taking care of kids with eating disorders in a residential community is navigating subspecialty care in a community where kids who feel like there is nobody else who understands them is surrounded by a bunch of other kids who are going through the same thing. The biggest difference is camp is a therapeutic community where we do not do therapy. Obviously, we do therapy in the psychiatric hospital for eating disorders, but really not. It's a pretty similar thing, and that's kind of how I got into it. No financial disclosures. Our objectives today, I'd like everyone to explain some of the medical complications of eating disorders in different organ systems, to identify clinical risk factors for medical complications of eating disorders, and to be able to say at least 2 ways that pediatric presentations can be different than adults or even than adolescents. Important things to remember: they are prevalent. Millions struggle secretly with food and body images. And even people who don't meet diagnostic criteria for eating disorders, many deal with food and body image issues. They're an illness, they're not a choice. They're complex conditions with emotional, physical, and cultural components, and there is definitely a genetic predisposition. They're lethal. People can die or have serious complications as a result of an eating disorder. And really the point that I hope to drive home, more than whatever the objectives I said, the point that I want to drive home is, yes, people die due to their eating disorders, but people also die because of their initial treatment of their eating disorders. And that's what I need to drive home. But most importantly, recovery is possible with the right level of care, the right people, right time. People can get better. It doesn't have to be a lifelong struggle. One other caveat I have to give: the biggest difference for me and the biggest struggle for me and the difference between oncology and eating disorder care is the lack of data, right? So the pediatric oncologists did a beautiful job starting in the 60s and 70s with doing multi-institutional studies where basically now every kid with, it doesn't matter if you're diagnosed in Roanoke or Jacksonville or Honolulu or in Fairbanks, you're treated the exact same way, so that we can increase the power of the studies, we have the N up, and in a much shorter period of time, we can figure out what works and what doesn't. Eating disorder, the field evolved in a completely different way, for better or for worse. Most kids with eating disorders who go through residential care are treated in private centers who depending upon where they are, may or may not play well together. They usually do, but certainly the data sharing, it doesn't happen, not because people are possessive of it, but because the mechanisms haven't been identified yet of how best to share it. Also, the numbers are smaller still. They are going up exponentially, but the numbers are still significantly smaller than the numbers that we have in cancer as far as people being treated in consistent ways and in consistent settings. Epidemiology, the age of onset is decreasing. Currently in children, the median age of onset is 12 years old. Cases have been documented as young as 6. And the prevalence of eating disorders in young males and ethnic and racial minorities is increasing. It has always been, the number that people have always touted out is 10-to-1 ratio females to males. It looks like it's about 6-to-1 in children. Who can explain this slide and why it has changed significantly in the past 2 years? This is a very different slide than it would have been 2 years ago. DSM-5 came out about 2 years ago. So until 2 years ago, we used DSM-4R criteria, which had been the criteria for about 20 years. So the biggest changes in the DSM-5, and there are a lot of them, anorexia nervosa. Diagnostic criteria used to be amenorrhea, which means no boys could be diagnosed with eating disorders or no prepubescent girls could be diagnosed with eating disorders. Now they can. The bulimia diagnostic criteria softened up a little bit. You don't have to binge and purge as often as you had to 2 years ago to be diagnosed with that. I am not a label person, by the way, and it sounds like I'm labeling. Why is that important? That I'm really trying to fit patients into these buckets? Why is it important I can fit them in? So they can get covered for their care. Because the insurance companies care about these diagnostic criteria. I don't care. The kid has an eating disorder, kid has an eating disorder, they need to be treated. But unless they can check the boxes, they're not going to get covered by their insurance companies. Binge eating disorder did not exist until 2 years ago. Suddenly, it's the most prevalent of all eating disorders because now it exists. Basically, the hallmarks are binge eating that is accompanied by distress or guilt immediately afterwards, and a lack of compensatory behaviors. That's the difference between bulimia and nervosa, where there is cycles of binge eating followed by compensatory measures. I actually want to go over those. The easiest way to remember them, all these are ways of purging. I call them the 4 Ps. That's how the kids remember them. You puke too much, sorry, breakfast. You pee too much, you perspire too much, or you poop too much. So laxative abuse, diuretic abuse, vomiting, exercise. Exercise probably the most common in our population, followed very closely by vomiting. Also, fasting is a compensatory mechanism. So if you follow binging by prolonged periods of fasting, you do meet diagnostic criteria for bulimia and nervosa. ARFID. Is anyone familiar with ARFID? So ARFID is one of the newies, and we are seeing it a lot, and we're seeing it in 6 to 8 year olds, a lot. And it's basically failure to meet nutritional energy needs due to an eating or feeding disturbance, usually associated with some sort of somatic complaint or fear. So it's not body image stuff. It's not fear of gaining weight. Most of these kids know that they're thin. The younger ones not so much because they have 6-year-old malnourished brains, so the insight isn't there. But it's not about a fear of being fat or getting fat or body image. It's about fear of choking, fear of vomiting, fear of something else, or something unexplained. And then other specified feeding or eating disorder or unspecified feeding or eating disorders. Other specified are you don't quite meet the criteria for one of the others. The other one is it's just there's something weird going on with eating, but you can't describe it. This used to be eating disorder not otherwise specified in the DSM-4R. Those are the criteria now. So anorexia has one of the highest mortality rates of all psychiatric illnesses. The risks are of death from the anorexia, a BMI of less than 13, less than 60% of ideal body weight, and a low serum albumin at the get-go. We hate BMI where we work. Why do we hate BMI where we work? because we treat kids, so the 20 that Aetna uses is not the same number we would use. So we do calculations of estimated ideal body weight. There's actually no gold standard for that. If there were a gold standard, the most recent American Academy of Pediatrics recommendation that I am aware of is you use 50% height for weight for height. We do not. We look at growth charts. We look at growth charts and we plot them to where they would be if they were there before they got sick, with the exception of a child who is above 80th percentile growing up, because many of our kids' triggers may be that they were overweight as kids. So we'll correct them down to 75 and then just kind of see metabolically where their set point is by trial and error. But we'll set them where they were before they got sick or at 75%, whichever is higher. The other thing that causes death in eating disorders, I'm going to say it over and over, is not so much the eating disorder as the initial treatment of eating disorders. And I don't think I have a slide for this, so I'll just say it now. The predictors of death there are also low weight, less than 70% of estimated body weight, and the trajectory of the weight loss. So the more weight that has been lost within the past 6 months, and more specifically within the last 2 months, the higher your risk of death during the refeeding process. It's not important because, well, what is important is you can't use electrolytes for anything. They really don't. For almost every kid we see, they're normal. If they're not, that's a problem, and that raises a red flag for us. It is almost never that we see an anorexia patient before treatment have a significant electrolyte abnormality, and it's rare that we see even kids who vomit 6, 7 times a day or use laxatives 5, 6 times a day to have electrolyte abnormalities. Their bodies, young bodies, just compensate better than older bodies for whatever reason. So we want you to get them, and we need to see them, and if they are abnormal, that's something you need to address. But if they're normal, that doesn't mean you don't have something you need to address. Quickly, binge eating disorder, lifetime prevalence about 2.8% probably, again, not been studied very long. 79% of people who are diagnosed with binge eating disorder meet another psychiatric disorder criteria. It is most commonly mood disorder. All eating disorders are more commonly than not associated with a comorbid psychiatric diagnosis. Medical comorbidity are basically the same as obesity. The mean onset is 18 years of age, and female to male is 3 to 2, so very close compared to anorexia numbers. Something that is really important to me to drive home, binge eating does not equal obesity. Obesity can be a symptom of binge eating disorder, but not everyone with binge eating disorder is obese. Well, most are. ARFID, we're seeing at about 15% of our new patients, 20-30% male, so again, much higher than in the anorexia population. Mean age of diagnosis, 11 years old, can start in infancy and childhood. 20%, I think it's significantly higher than 20% anecdotally. Display preoccupation with somatic concerns like fear of choking, vomiting, or illness. Anxiety disorders are the most common psychiatric comorbidity. So you have a kid you suspect may have an eating disorder. What do? You talk about their course of illness and triggers. You ask about restricting behaviors, counting calories, dieting, skipping meals, fear foods and safe foods, hiding and throwing out food. You ask about purging behaviors. We went through them. Also ask about fasting after binge episodes. How often is there a ritual behind it? Do you go to school, watch a TV show, binge and purge every day? That's actually overall a poor prognostic sign, but a good prognostic sign for immediate treatment, meaning if we do nothing else but get them into residential care and break the cycle, that's really helpful for them in the short term. Long term, that seems to be a poor prognostic sign. Binging behaviors, eating faster to the point where you're uncomfortably full, large amount of foods when you're not hungry, alone and in secret, do you feel disgusted or guilty afterwards, frequency and timing, and then body image is really important for our kids. Our average age of admission is currently about 13 or 14 years old, so it is super important because the treatment is very different to differentiate out whether they have body image issues or not. We have to rule out organic causes. As you can imagine, this is getting better and better. You know, as the years go on, the stigma attached with any psychiatric illness, and specifically eating disorders, is, you know, getting less and less, but it's obviously still there. And so there are some parents that have a really hard time of letting go of the fact that there must be something medical causing this. Depending upon the symptoms, some measure of diagnostic evaluation may be warranted. Usually by history, though, you can tell that they don't. But at least in history, in your brain, evaluate for GI disorders, neurological or structural issues, food allergies, which is a big problem for us, as you can imagine. Talk about body image concerns, rule out any cultural practices there may be, and you know, really interesting, and really investigate, not so much on first visit or in a primary care setting, but one of the things that our therapeutic staff really investigates are these cultural issues. So for example, we have currently a kosher patient who, once we got to know the family, it turns out that the mother has said that they can't eat any fish. I know kosher. I know kosher really well. And so is putting a lot of her own eating disorder behaviors, which we see all the time, on the cultural practice, when it's not at all about the cultural practice. It actually has to do with what other eating, I don't want to say eating disorder behaviors, although in this particular case it is, but any eating habits that have been developed through the years, and put them on cultural or other some sort of external reasoning. Again, differential diagnosis, symptoms that we see are abdominal pain, appetite loss, fear of food, fear avoidance, weight loss, and failure to meet trajectories. Talk about this. So signs and symptoms. This is kind of my every all-comer slide of every organ system. So how does chemotherapy work? Chemotherapy destroys all dividing cells in your body, basically. How does starvation work? You need energy for cells to divide. So the side effects of chemotherapy are very similar to the medical effects of eating disorders, yet another connection. I do like to use the connection of cancer a lot, one, because I know it, and two, because it is, depending upon the peer reviewer you get on the phone, but more importantly for the families who try to medicalize all of their psychosocial issues. Using an analogy like cancer, which is a real disease, real quotes, real disease, sometimes can bring it home. These things happen in cancer, and these things happen in eating disorders as well. So weight loss, weight gain, failure to meet projected growth trajectories, amenorrhea or changes in menstrual cycles, decreased frequency of erection and nocturnal emissions, delayed puberty, abdominal pain, constipation, fatigue, exercise intolerance, cold intolerance, bruising, delayed wound healing, pale or dry skin, hair loss. Who knows what rust? Well, I defined it, so don't. It's scars or abrasions on knuckles. Bruising along the spine. Why would that be? There's no fat. Tooth decay, yellowing of the teeth, and headaches. I'm going to hold on that. Cardiac symptoms of eating disorder. So they're different, right? Depending upon whether you have severe malnourishment in anorexia or ARFID, or whether you have frequent purging, especially through either laxatives or self-induced vomiting. So the cardiac disease in malnutrition is cardiac muscle atrophy. The cardiac disease in the theoretical cardiac disease in binging behaviors is electrolyte disturbances causing arrhythmias, right? So the sudden death that we more commonly see, that is more commonly seen, is sudden cardiac death from cardiac muscle atrophy. The heart just stops beating. It gets so weak that it stops beating. Basically, the heart is going to conserve, because it is so weak, it's going to conserve as much energy as it can. So when a patient with anorexia is lying flat, what's their heart rate going to be? super low. They are hibernating like a bear. They are really hibernating like a bear. They are conserving as much energy as they possibly can. So when I say to a child or to a parent, your kid's heart is really sick because your kid's heart rate is 38, what is that parent or child going to say to me immediately? That's because I'm an athlete. They're immediately going to say that. Every single one of them, parents and child, will both say that. How do I prove them wrong? How do I not prove them wrong but attempt to? What's that? Yeah, so the orthostasis we see, we have had kids in our hospital. I'm going to talk a little bit about the difference between the kids that we see and the kids that you see, because there are a lot of kids that you see that I don't want to see yet, because we are a psychiatric hospital that has medical services. We are not a medical hospital or anything close to it. We have seen and taken care of kids who go from 38 to 110 from lying to standing. And basically the way I explain it to parents, and this is kind of the way I explain things to everything. I'm sure he remembers I'm going to show a slide with like phosphate and electrolyte. I don't remember any of that stuff. But I remember what happens, and I remember what happens in the body. So basically what happens in the body when somebody with a weak heart stands up, their heart can't beat any harder because it's super weak. The only way you can get blood up to the brain is to beat faster, right? Whereas Lance Armstrong, back in the day, when he lied down, his heart rate was in the high 20s to low 30s. And when he stood up, they went to the high 30s to low 40s because his heart could beat harder because his heart was in shape. That's the difference. As far as electrolyte abnormalities, potassium and phosphorus, super important, lose them both. You know what, I forgot. So I talked about the 4 Ps. The reason that the 4 Ps are important in purging, which are puking too much, peeing too much, pooping too much, and perspiring too much. What do they all have in common, those 4 Ps? What do they all cause? Well, dehydration, and then usually with an accompanying electrolyte loss as well. So there's a fair amount of hypokalemia and hypophosphatemia that we see in patients who chronically purge. Again, though, more commonly than not, they're completely normal. But if they are abnormal, those are the most important electrolytes in that big circle and the things going in and out that can cause a potential arrhythmia. The one thing I do want to address is QTc interval. So there is, the gold standard is with a QTc elevation, a kid is going to be at higher risk for refeeding syndrome. And if there is I'm lying. If somebody has if there's a prolonged QTc, if there is an electrolyte abnormality from refeeding, then that child will be at increased risk for arrhythmia and sudden death because of the underlying QTc. It's actually more thought now that it's not about the QTc, but it's about the QT dispersion, which is difficult to get a cardiologist to measure, and I can't measure. We still generally use a QTc, and our cutoff for just wanting a cardiologist to bless a patient has gone from like 4.44 to 4.5 to 4.7. So we'll actually take up to 4.7 now without necessarily freaking out about it. And almost always these kids' QTCs go to normal after about a week of renourishment. Pulmonary, mostly related to purging disorders, so aspiration pneumonia for obvious reasons if you chronically purge, pneumothorax from pressure differentials, and then occasionally pneumomediastinum, which can be secondary to Borjo syndrome. Anybody know what Borjo syndrome is? So it's any rupture of the esophagus. So the fact of the matter is the pneumomediastinum isn't going to kill the kid. The bleeding out from the Borjo syndrome. It is extremely rare. I think it's reported once every other year or so, but it can occur from weakness of the esophageal lining and chronic pressure in the esophagus. Endocrine metabolic heme, really this is my chemotherapy slide. It's all the same stuff. So we see pancytopenia all the time. The difference is, and we've seen neutropenias down to 700 or 800, probably not a functional neutropenia. So the difference is kids with cancer on chemo, their white cells, they don't have them and they don't work. Looks like the white cells that these kids still have do work. We're not quite sure why that is, but we do not see overwhelming infection in our population. Thyroid atrophy, in severe cases, we see thyroid abnormalities just like you would see in any chronic disease that always gets better with time. A couple times a year we'll diagnose a new hypothyroid, but I don't think that's any different than what happened in the general population. I don't think we see it any more often than anybody else does. Now, of course, thyroid abnormalities can be the cause of weight loss or weight gain, so we do want to screen for thyroid before kids come in, but the most common thing we see is a sickle thyroid. Growth hormone abnormalities, really, and again, you think at the time that these kids can start to get their malnourishment and eating disorders, there is a risk, depending upon the time, of their failure to meet predicted adult height. Cortisol abnormalities, there tends to be high cortisol as a stress reaction, probably from starvation. What's really interesting to me, has anyone here taken care, like, through a spectrum of a kid with an eating disorder, from diagnosis through recovery? So when a malnourished one, so the distribution of fat initially when a child starts to gain weight, or an adult, is really distressing to them. Why? Where does it come first? And here. It's really like a Cushingoid presentation. It looks like a Cushingoid kid. It has not been studied, again, because most of these kids aren't treated long-term in academic study centers. I really think there's some sort of cortisol, something or other going on with these kids for their initial weight gain. Talked about electrolytes, and we talked about pancytopenia. HENT, a lot of this is just electrolyte deficiencies in the skin, so the inability to close eyes. You have a super taut skin. That's from malnourishment. Perimyelitis, caries or teeth erosions, specifically in the interlingual surfaces of the teeth. Some of these changes are really pathognomonic for chronic vomiting. The first line of diagnosis for adolescents with chronic purging should be the dentist. There are two potential reasons why it's not happening. One is because they don't recognize it. It may not be in all training programs. And two is because they don't know what to do with it if they have it. And I actually have heard this secondhand, that a dentist actually saw it, suspected it, and was afraid to say anything. And I don't necessarily blame the dentist for that. That's a training piece. Speaking of training, average number of hours of eating disorder treatment and eating disorder teaching and exposure a 3-year pediatric program has across the country, about an hour and a half. 4-year child and adolescent fellowship, about a week. And it is the most common psychiatric illness in child and adolescent psychiatry. There are child and adolescent psychiatrists who will not take care of eating disorders because, not because they don't want to or because they're hard, and they are hard, but because they feel like it would be irresponsible because they don't have the background to do it. It's a sad fact. Pharyngeal soreness from chronic purging, inflammation in the corners of the mouth, both from malnourishment and then from chronic irritation of acid. Cyanidinosis, parotid gland swelling. When is that the worst? It's acute cessation of purging that really causes it. I mean, so people who chronically purge have enlarged parotids, but they get really, really big when purging stops. There are 3 ways, and I'm only going to be able to think of 2 of them off the top of my head. 3 ways, I thought of all 3, that the body is stupid in the recovery of eating disorders. So I talked already, the body's pretty smart, especially in kids, in maintaining electrolytes, doing the best it can to stay healthy, knowing to go into hibernation to conserve energy. When someone stops purging acutely, there are 2 ways that the body doesn't buy it. One is the salivary glands continue to produce saliva for about a week to 10 days, and it's got nowhere to go. And that's why it causes this. And there's almost no way to treat it. The other way is the kidney doesn't buy it. So again, you think of the 4 Ps, and you think of chronic dehydration. Aldosterone is going to do everything it can to hold on to every ounce of water that your body has, and when you start getting hydrated again, the kidneys don't buy it. And for about a week to 10 days, you continue to retain water, and it can cause, more so in adults than children, significant edema, which is ridiculously uncomfortable and distressing. There are some that argue that the reason that outpatient treatment for purging disorders fails as often as it does is because this is so distressing to patients that they just decide to puke again because it's easier than dealing with it. It's not any, now we can't, it's not true. Rarely, we have to be really careful of diuretics, right? Because diuretic abuse can be purging. Occasionally, we will use a tiny whiff of aldactone with severe, and especially if we see a high bicarb with a severe retention edema for about a week. But we really try not to. We use compression stockings, we raise the legs, we use warm compresses on the parotids. It's really symptomatic care, but also the psychosocial support you have in a 24-hour setting, as opposed to going home and just saying, you know what, it's easier to just vomit again. From a GI standpoint, dysphagia, again, usually in purging disorders from the irritation of the throat. We talked about Boerhaave, Barrett's esophagus. So when food gets into the esophagus wants to act like an intestine. So it has been reported that Barrett's esophagus can occur in people who chronically purge as it can in chronic reflux. Again, though not carefully studied, this is actually probably more theoretical than it is reported because of the lack of studies in our population. Reflux, basically it's mechanical. It's supposed to be a one-way valve, right? And it's muscle. And when you make yourself vomit, the pyloric sphincter just becomes a two-way valve. So it's just as easy for it to come up. It does strengthen, we think, with time. After about a year, reflux can improve. We really only treat it symptomatically. So if a kid has significant reflux symptoms, we will treat it. We have never had anyone go to surgery to repair it. Cathartic colon is just lack of use. The colon isn't used to contracting, so it takes a while for the colon to get its musculature and its neurologic activity back. Every single kid we have is constipated. Every single one of them. Again, not studied what to do about it. There are centers that I respect as much as ours that put kids on Miralax 3 times a day automatically and keep them on it throughout. I use Miralax PRN. We use Colase PRN, and then we hit them with mag citrate and then an enema. We don't want to obviously use stimulant laxatives on our patient population. It is real, it is distressing, and it will go away with time once nourishment occurs. SMA syndrome, I think you guys had one that came to us, I think. So SMA syndrome is basically a duodenal obstruction. The duodenum passes between the superior mesenteric artery and the abdominal aorta. There is a fat pad that is really important between the superior mesenteric artery and the duodenum. And with chronic malnourishment, when that fat pad goes away, there is a functional obstruction of the duodenum. And the only way to treat that is to get the fat back. And the only way to nourish somebody with that is an NJ tube because it has to go beyond where that obstruction is. It's tough because we do NG feeding, we don't do NJ feeding. So there have been a fair number of kids who have been in our waiting line because we need the SMA to resolve before we can admit them because we just don't have the licensure. It's not that we wouldn't be comfortable with it. North Carolina licensure is a big issue. It took us a year and a half to be able to do NG feeding. So they have to get treated elsewhere until the SMA resolves. Although I will say, in retrospect, I'm about 90% sure we just treated, unfortunately, somewhat uncomfortably, a kiddo who probably had SMA with us, who was unable to take food, who was able to take some supplement, had significant discomfort, and then suddenly when she hit 80%, it was all better and all gone. So we didn't really, quite frankly, think of it in prospect, but in retrospect, she probably did have SMA syndrome. Hepatitis can be from starvation. It also can sometimes occur in refeeding. Acute renal failure from dehydration, very, very rare, and renal stones occasionally from, I touched this and I wasn't supposed to do that, and now, oh, thank God. Okay. Dermatologic, again, mostly from nutritional issues. So super dry skin, probably from mineral deficiencies. Alopecia, just like chemotherapy, it's exactly the same. When is hair loss the worst in recovery of eating disorders? I just said it. Yeah, just answer my question again. When in the trajectory is hair loss the absolute worst? About 6 to 8 weeks into recovery, because that's when the new hair comes in. It's really cool because the kids freak out and then they hear that that's why, and they just love it. Brittle nails, again, from starvation. Lanugo, I skipped. Really, the body's mechanism of protecting itself from the cold. Starvation-associated pruritus is probably not hepatic related. Nobody knows exactly why it occurs. It probably maybe from the dry skin or the mineral deficiencies. Stress-related urticaria I think is super interesting because we have had maybe 4 or 5 kids who had an allergy to something and developed hives with the something. And as it turned out through trial and error, they had stress-related urticaria to that food, and they absolutely did not have allergy. Through allergy testing, we saw that they didn't actually have an allergy, which, you know, I always look at allergy testing. I really tend to try not to get allergy testing because many times, and especially for parents who are already hyper anxious about what their kids are getting in, we will often see false positives. And so a kid who's been eating fine with us for 2 weeks, we get allergies and they're allergic to this, and this. We've been giving them this, and this for a month and a half, and they've been fine. So I really try to shy away from getting allergy testing on my watch, and Russell sign we talked about. So young children with eating disorders present differently than adults. Again, no amenorrhea if they're premenarchal. They may not be significantly underweight according to their growth chart. Their behaviors are often hidden or not present if they have ARFID. And again, their biochemical presentation may be completely normal and unremarkable. Refeeding syndrome, which I think is the most important thing that I can talk about with this group of people or in any hospital setting where you're taking care of kids who may walk in the emergency room to get their first treatment for malnourishment. So it is thought that the real culprit in refeeding syndrome is hypophosphatemia. And again, this is my way of explaining it. This is like that way of explaining it. This is my way of explaining it. The third way, the body's stupid. So the body's been starved for a long period of time. The pancreas hadn't have to do much, just been kind of hanging out, right? All of a sudden you start to eat. Awesome. Pancreas gets super excited, puts out a ton of insulin. Sugar goes down. Oh, by the way, because of the stuff on that circle that I don't understand, potassium and phosphorus also goes into cell, which is the directive insulin, they tell me. I apparently knew that at one point. So it happens. I know it now because of what I do, and it is specifically the hypophosphatemia that can lead to arrhythmia and can lead to sudden death. And it happens in this country probably about once to twice a year. And it should not necessarily specifically in the eating disorder population, in any cachexia that's treated quickly. And it should never happen. There's no reason for it to happen. It is completely 100% avoidable. In our population, I can't touch that. In our population, the risk factors are BMI of less than 70, and the patients who lose weight more quickly in the previous 2 months. The refeeding hypophosphatemia incident rates in anorexia in adolescents is about 14%. That's not refeeding syndrome. That's just us seeing the phosphorus start to go down while a patient starts to refeed. There's that. How was refeeding syndrome discovered? Oh, thank you. Thank you, right? So World War II, concentration camps, many concentration camp survivors had been starved for a long period of time, suddenly got out, the people in the towns fed them, they were doing a great deed, and they all died. They didn't all die. Some of them died from refeeding. But that's not the right answer. But that's the answer I want, so thank you. Because the tragedy is it was discovered about 2 years earlier in the Ansel Keys study at the University of Minnesota, where they studied conscientious objectors. So conscientious objectors to World War II volunteered for a starvation study, and they went through the starvation study, and they were all fine. And then they all ate and they all died. They didn't all die. But some of them died, and they died from refeeding syndrome, specifically hypokalemia, probably more importantly, hypophosphatemia. But back to the concentration camp survivors, which ones did the best? And this is, I'll give you the disclaimer in advance, this probably is anecdotal and not real, but it helps me remember it. What's that? The kids, the townspeople that gave the survivors chocolate did better. Why? Chocolate has phosphorus. That may or may not be true, but it's a story that I've heard that has stuck with me, and it helps me remember it. All right, so there's a 15-year-old boy who's got a BMI of 13, currently weighs 89 pounds. His heart rate's 120, blood pressure 104/68. His EKG says sinus Brady, so why is his heart rate 120 if his EKG says 58? Because more than half the time when we get vital signs from emergency rooms, there are no orthostatic vitals. There is a set of vital signs. And if a patient is in the emergency room who clearly is malnourished or clearly dehydrated and is in the emergency room for 24 hours, there are vital signs generally every 4 to 6 hours, one set, not orthostatic. I mean, really just from a dehydration standpoint, it's a kid who probably should have had orthostatics. ANC is 1200, chloride 69, phosphorus 3.4, has known struggle eating disorder for 2 to 3 years, has many GI diagnoses since birth and is afraid that feeding will be painful. He has restricts. He has a history of purging but is not currently purging. No current behaviors like exercise or hiding food or cutting, rituals like cutting into, I didn't mention this, rituals like cutting into small bites, eating one food at a time. Those are signs of anorexia as well. No psychiatric comorbidities that we know about, doing well in school. By the way, as probably most of you know, all of our kids do well in school. So even though our kids' brains are ridiculously malnourished and the wiring isn't there, the thing that is almost always spared is academic ability, which again, a parent will say to us, how can my kid be that sick when they're still getting straight A's? And the fact of the matter, one of the things I can say is look at your kid who's getting straight A's today and look at your kid who got straight A's a year ago. Your kid's not spending 3 times as much time on their homework because 8th grade is that much harder than 7th grade. It's probably because your kid is super malnourished. The things that, on a day-to-day practical standpoint, that malnourishment seems to show us in the brain are things like rational thinking. Like a kid gets that they have to get better nourished for them to be healthy enough to participate in sports. And all they want to do is participate in sports, but they won't eat to do that. And they can't really draw the connection until generally like 80%, and then they get it. They still don't want to eat. They still don't want to gain weight, but they're able to connect the dot to say, to do that, I have to do that. And that's just, it's really not there in many of our kids. 80% is about the magic number. So this is a kid, for various reasons, has lost 7 pounds in 3 days, 26 pounds in 6 months. This kid is at risk for refeeding and really should be hospitalized. PCP recommended to go to the ER, was admitted to, for medical stabilization, was released in less than 2 days with a fluctuating phosphorus and fluctuating potassium. This is dangerous. This is a real risk for refeeding syndrome, which I didn't give the timeline, 5 to 7 days. So and here's another really interesting thing that I've caught myself in too. Who here has referred a patient to us? I apologize in advance for our form and our checklists. So here's the thing about the checklist. It's all the stuff we need, and I know it's a pain, and we always are trying to work on it, and I know it's still a pain. It's an explanation, not an excuse. So there's a checklist, right? So we have our type A kids with our type A parents who feel like if they check all the boxes, then they can come to Veritas. Well, we have the boxes there for a reason, right? So if you get your 10/20 and your potassium is 2, no, you can't come to Veritas just because you checked the box. Similarly, we always say, out of my mouth, up until very recently, we need to see 5 to 7 days of stable electrolytes, stable telemetry, or at least stable EKGs. Well, that's 5 to 7 days from when the kid starts to get nourished, not 5 to 7 days from when they walked in the door. Because many kids who will go to a hospital, and I actually don't have a comment on this, I don't think it's good or bad or it's somewhere in between. Sometimes when a kid walks into a door of a hospital, that's the motivation they need to start eating. So they don't necessarily need an NG tube dropped immediately if it looks like a kid is going to start eating. So if vital signs are stable and you're comfortable, you have the ability here to have a kid on a monitor, to check labs every 4 to 6 hours. If you want to sit and wait for a day or two, that's fine, go for it. I would rather the kid eat. But the clock doesn't start until they actually start to get renourished as far as the risk for refeeding. So we got in touch with the family and had that kid admitted for the 5 days. 15-year-old female, BMI of 13 and change, weight of 73 and change. Not really orthostatic, but a little bit, well, no, that's okay. Electrolytes have fluctuated for the past week, does have a prolonged QTC. Potassium has been as low as 3. Phosphorus has been as low as 2.8. Has had eating disorder symptoms for about a year and has classic anorexia symptoms. 25 pounds in 2 years, 11 pounds in the last 6 months, meets criteria for inpatient hospitalization. Telemetry for 5 days is what we like to see, and I will give you this caveat. So I feel really, really, really strongly that these 2 kids in particular, and kids that we see are sicker, need to come in and be hospitalized for 5 to 7 days of refeeding. Blue Cross Blue Shield probably disagrees with me, and I know that there are people in this room who have been caught in between. I will not take this child in my psychiatric hospital where I can draw labs once a day, put them in the plastic bag, have the LabCorp van come, sit in the van, shake all the way to Greensboro, sit overnight and get run the next morning, have the glucose be 28 because it's all iced. The potassiums are all 703 because they've all iced. So no, I'm not going to take care of that kid in my hospital and with our EKG machine that we roll in and then I'm the one looking at it. And then we send it to the real person who knows how to look at it, and we get that back in 2 hours. No, we're not the place for the kid. We take really good care of our kids when they're ready to be with us, I promise you. But we are not equipped to take really good care of kids who are at really strong risk of being medically sick in a very short period of time. So it's a battle, and I know you guys have to fight it. They're not meeting insurance criteria. If their vitals get normal, if their electrolytes are normal, they got a bolus. The insurance company doesn't care that they lost 30 pounds in the past 2 weeks. The insurance company cares that their vitals are normal and their electrolytes are normal. We are trying to change this, we meaning the field, we meaning public health in general. It looked like things were getting better for a long period of time. We actually were really successful. Again, we meaning the field. There was a bill that was before Congress called the Anna-Weston Act that was rolled into the big healthcare bill that was passed in October of last year. But the Anna-Weston Act, when it stood by itself, had a mnemonic of 3 T's. It was training. So the hope was to be able to designate already existing SAMHSA funds to go into the training of professionals who might have contact with children with eating disorders. So professionals means doctors, dentists, school counselors, school nurses, any professional to be able to increase the number of touch points to have eating disorders on the radar. Number 2 is treatment. And treatment is, on our end, I'm on the phone much of my day with peer reviewers who know my patients better than I do. Mostly the psychiatrists do the peer reviews, to be fair. I used to do a lot of them. I don't do them so much anymore. And 2 things. One is the criteria they have are very different, although we've been successful in changing anthems to meet APA criteria, which I'll show you in a second. but the real piece of the treatment part of the Adolescent Act was treatment or access to care. So about 15 years ago, there was a bill passed where the parity bill, parity in mental health and medical health, where basically the analogy that I've always used is if you are covered for rehab after open heart surgery in a rehab center, the analogy is residential care in a psychiatric hospital. Many behavioral health plans completely excluded residential care. Eating disorders was a loophole in that. It wasn't supposed to be, but it was because of the bridge that eating disorders cross between medical and psychiatric. And so many plans specifically excluded residential care for eating disorders. That is no longer legal. So anyone who has long-term care medically has legally residential care for eating disorders as well. So that was the T. That was the second T. The third T did not make it in the final bill, which was truth in advertising. So we wanted a study funded to look at the effect of digital alteration of photographs to see if that was a trigger for the development of eating disorders. As you may know, both Israel and France have minimum BMIs for print models. We were not asking for that, because that would not have happened for sure, but we were asking for money to study whether or not there is an effect. That got dropped, but the other two did get passed. So again, variables to consider: rate of weight loss prior to treatment, extent of malnutrition, method of refeeding. Carbohydrate load on the front end may lead to a higher risk of refeeding syndrome, which is why the RDs have to be absolutely hand-in-hand involved with this process. And the rate at which nutrition is introduced. This is really, really important because this is not accurate information, and it's what we do, and I'll explain why. For years, it was always thought that the best way to prevent refeeding syndrome was to go slow and steady. So we basically, and we still do this, I'll explain why in a second. We meet the kid where they're at, or at about 900 to 1,000 calories, whichever is higher. So we'll meet the kid where they're at and basically go up 200 to 300 calories a day over every 2 to 3 days. Monitor their electrolytes, supplement phosphorus PO if necessary. Prealbumin, did not talk about this, by the way. We don't monitor prealbumin. We check prealbumin. Prealbumin less than 20 doubles the risk of development of refeeding syndrome. So prealbumin is a nice little marker to use. Not refeeding syndrome doubles the risk of getting hypophosphatemia or hypokalemia. And again, 2 to 3 pounds per week. 2 to 3 pounds per week is the goal of the 200 to 300 calories a day every 2 to 3 days. When they reach their weight, then we start to back off. There have been several studies, and in fact, even a recent article in Peds in Review that has argued that you can go a lot faster and a lot more aggressive than this. And that's true. You can. If that's done, though, that study was done in an academic hospital where you can get labs every 4 to 6 hours and the answers that day without them going to Greensboro, and where you can have telemetry or EKG. We don't do that. So I'm all for you guys, if you have the resources and the references in place and you're comfortable doing it, go faster. It's fine. It's absolutely fine to go faster. We won't because of the medical limitations we have. I will also argue, and I don't know whether this is, an argument, whether I'm rationalizing it or not. We also don't want to rush our kids out the door because the therapy that they're getting is really important. That's what we do. I mean, we are a psychiatric, and I see the time now. We are a psychiatric therapy-based program. Our therapists run the show. They are the navigator of the ship, and the parents know that. And that is the basis of good residential care. Therapy is the most important piece. To kind of put it into numbers, each of our therapists carries 5 kids, each of our dietitians carries 10, each of our psychiatrists carries 16. I, as a general pediatrician and as the chief administrator of the hospital, carry 40. By the time they get to me, they shouldn't be so sick that I need to see them all the time. Now, of course, that can be challenging for parents who want to talk to the doctor. That's the education that we have to do from the parents. And, but it is a therapeutic hospital, and the therapeutic piece is the most important part of what we do. And I'm actually going to stop here because I want to leave a little time. So question, you have a way to do that. I don't
Hang on.
know what that is.
I'm the general pediatrician that's outpatient, and I've had a couple kids that I've struggled with, even getting them to accept care.
Right.
And can you tell me like 2 minutes about, I almost want to say recidivism, but relapse rate?
No, because it's not, the numbers aren't there, the studies aren't there. One of the things that we know anecdotally from unpublished data, because we don't have IRBs and we don't have cooperative studies, it appears that if a patient enters residential care, we can't speak, and you know, talk forever about the modalities of the therapeutic care itself. There's family-based therapy, there's cognitive-based therapy, we do dialectical-based therapy, which is an offshoot of CBT. Patients who do, and you can't do family FBT in a residential hospital unless the parents move there. So for us, for our based residential care, DBT-based, if a patient comes in, if they leave residential care prior to hitting 95th percentile of their estimated body weight, they are twice as likely to relapse as if they saw treatment through. We have 3 levels of care in our facility in Durham, and and anyone who wants to stay after, I can talk more about the facility. That's not why I'm here today, though. But the levels of care from a psychiatric standpoint, though, are inpatient level of care where they see a doctor every day and they live there, residential where they see a psychiatrist once a week, therapist several times a week, all group therapy, and they live there. We recommend that to attainment of ideal body weight plus 2 weeks, because that's when they generally all freak out. And that's when actually they can become, the second time they can become somewhat hypermetabolic, so their meal cards may increase. Keep them there for 2 weeks, and then a partial program where they go home at night or to the Ronald McDonald House, because most of our families aren't Durham local, for 6 to 8 weeks before they go out into the community. And that's anecdotal.
How effective are goals like you can't go out for cheerleading unless you get over it, or you can't go out for the basketball team?
So it's interesting. We have, and we've evolved with time. During treatment, most of our care, we said absolutely no physical activity whatsoever. I think that's irresponsible. We've changed that to some extent. We individualize care greatly, and we try to look at what, if any, their sports had to do as far as triggers of their eating disorders or components of their eating disorders. Obviously, we have a lot of dancers. And there are some kids that we actually recommend, at least for the short term until you get to outpatient care, that you not dance, period. So that's tough, so you don't have that. For the other kids, it can be super motivating. Or another goal that's not physically related is probably healthier in this population, especially the population where exercise was a component of their eating disorder. Figure out some other goal. That's vacation to Italy you were going to take in the summer. Having a normal junior year of high school, going to the prom. Goals like that actually are helpful in motivating people. Seeing the light at the end of the tunnel one way or the other has been motivating for our kids. Because we got a lot of kids who are stuck and who aren't eating, and we can't do force feeds, and they can refuse NG tube feeding. We try not to publicize that, and it depends on our milieu, right? Once one kid figures it out, they all figured it out. But in general, goals like that have to do with being home or normalization of their lives amongst peers at home can be really helpful.
Can you please tell me a little bit more about the length of stay of this kid in the hospital?
Yeah, so our average length of stay is between 80 and 90 days, I think, all levels of care. But it depends on where they come in, right? So we do the math. When we project the length of stay, we do the math. 2 to 3 pounds a week to hit 100%, plus 2 more weeks of residential, plus 6 to 8 weeks of PHP. Most of our kids are 80 to 90 days across inpatient, residential, and partial. We really strongly recommend they do all 3 of those levels with us. I would say 80% of our families stay with us with partial no matter where they come from, so parents are the real heroes. They pick up and move because they have to take their kid home to the apartment or to Ronald McDonald House or wherever they happen to go every night.
One of our BCI, talking about the complications of dental enamel problems that the dentist may not refer directly because of questions of concerns about an eating disorder, but they do send it to us and probably the primary care physician because of reflux possibilities. So us as out there, we need to really keep an eye into what of these possible reflux are actually could be a.
That's a really great point that I've never actually
to keep that in mind.
Yeah, I've never actually said that, but yeah, absolutely, because these kids are going to keep, this is a secret hidden disease, right? So they're not going to volunteer any information. So anything like reflux is not normal in a 12-year-old. And before you send them to GI, ask questions. That's a great point.
Sheila Vesney, Child Adolescent Psychiatry. Because of the lack of training and the lack of outpatient resources in the community, I see a lot of first diagnosis, need of medical hospitalization for stabilization, reflex referral to residential. And so I'm curious if you could talk about where does residential treatment fall in the algorithm of treating eating disorders?
So, and again, I'm really worried about time, which I feel badly about. So here are the indications for medical hospitalization in general. So it's, no, they're not. I'm lying to you. These criteria could also be inpatient psychiatric hospitalization. In general, it's the things that I talked about. If it's a BMI less than 70 to 75%, I'd rather not them come to us yet. If there are electrolyte abnormalities that are not able to be steadied for 5 to 7 days, so I'm not going to not take a kid who's 2.8 if you can get the 2.8 to 3-ish for a good 5 to 7 days. I mean, just, I can't rattle them off, and it's sort of it's obviously an art, not a science. But if they've got stable vital signs and they're above 75%, we'll probably take them at residential. You're talking about medical hospitalization versus psychiatric hospitalization, right?
When you stabilize the kids medically, how do you decide whether they should have a trial of
outpatient versus residential?
Versus residential.
I would think somebody who needs a medical stay probably should go to residential, is my gestalt, because it's gotten pretty far pretty fast and the family clearly needs education. There are some that would argue with that, and certainly the FBT people would completely argue with that. So there's, and that's, quite frankly, more studies have been done and the academic gold standard for sure is FBT. So there are going to be a lot of people in the community who would argue with what I just said. My gestalt is that, and nobody knows for sure.
I think we are over time, so we'll have to wrap it up there. Thank you very much. If you're still on the line, sorry we ran out of time. You can always email me at outreach@carillionclinic.org, and I'd be happy to get them to our presenter. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.
Yeah, hi.